we are facing a sort of doomsday scenario in a couple of areas. One is, as we trend into adult life, obesity is a huge problem. But also what's happening is in our unhealthy lives, we are accumulating more and more chronic conditions. The ambulance took 4 hours to arrive. Is out. And I don't see anybody in Parliament, anybody in politics talking about this, thinking about it. This is a huge issue. This is a disgrace. This is a never event that should never happen in our system. We're talking about 60 to 70 years of life lost because we didn't act appropriately.
The NHS is in crisis. Waiting lists are at record highs. Accident and emergency is buckling and winter is around the corner. Professor Carl Heneghan, director of Oxford University's Centre of Evidence-Based Medicine, says the problem isn't just lack of money. He believes vested interests and industry have captured the health service. Carl runs the Trust the Evidence Substack with colleague Tom Jefferson, where they dissect health claims and policies with hard data. And all too frequently, they find we're paying billions for tests, diagnostics, and drugs that do little or nothing for most patients, while emergency and cancer care are starved of resources. Carl warns that unless we change course, the NHS will bankrupt the country. Carl, thank you so much for joining us.
You're welcome, Ralusa. I think you paint a stark picture, which it feels troubling and worrying, but I think the concept you're introducing is this problem we're calling now too much healthcare. And in doing so, we're about to put another 20 billion into healthcare, and that will take spending to 200 billion. And yet we sit here today with huge problems in the healthcare system. I think the latest data about cancer care is truly troubling. Cancer Research UK revealed only 75% of people urgently referred for cancer had it ruled out with 28 days. That's ruled out. Of the people who had a cancer diagnosis ruled in, went on to have cancer, only 57% in 2021 were seen within the target 28 days, which fell to last year to 52%. So half of the population here, imagine you have your GPs referred you. This is not just people coming off the street. This is your GP has a high suspicion you have cancer. You could have red flags like you're losing weight. You've got all sorts of symptoms that are concerning, like a persistent cough. And you're having to wait 2 months for a diagnosis to rule it in. And that's before you get then to the treatments and potential cure. Now, what's happening is we're seeing people on the waiting list who are then going on to have changes in the stage of the disease. And I suspect huge numbers of people are dying while on the waiting list. And this is why we have some of the worst rates in Europe of cancer outcomes. Now, what I consider should be happening here is what's happening is we're distracted by prevention, more screening, more targeted screening, and forgetting what is needed here. Once you have a diagnosis of cancer, we should be seen and treated within a week. So you direct some of your healthcare to priorities, where you think you can make a difference and the evidence is. And then you stop doing other things. And I want to give you some example. For instance, 8.9 million people are on antidepressants in this country. It's about 1 in 7 people, 93 million prescriptions per year, despite the evidence in primary care that actually in the community, mild depression is the outcome from taking all of these antidepressants isn't going to change what happens next.
You're saying
it just medicalizes a huge
depression, it doesn't work. Would the trials show that as well?
Yeah, so what happens here is if you look at the trials, the randomized controlled trials in the community primary care.
This is when you've got a dummy drug and the real drug, and you compare people who don't know.
Yeah, correct. Yeah. And you randomise. First to say, what happens is them trials are short in duration. Many don't go beyond 16 weeks. Actually, by the time you get to about a year, there's only about a couple of thousand people in the trials to infer what to do next, despite I've said over 8 million people are on the drugs. In addition, what they show is a small statistical difference in measures of depression. But actually, the clinically significant difference is not there and not apparent. They just do not change the course of what happens next. And what's happened is we have continually medicalized what I consider is normal parts of daily life. And we are in a...
And depression, but you've looked at other things, this prevention and vaccines and screening. Surely, just antidepressants can't explain why we're misspending.
No, that's just one example of where we're at, of where we need to focus and say we've gone down the wrong track. It sounds like the option is always more is better in healthcare. But actually, when it comes to prevention, most of the simple things are what does us the best. Stopping smoking. Don't eat too much. Don't particularly drink too much alcohol. I'm not saying abstain completely, but what you need to do as you approach middle and later life is, in effect, you have to take more responsibility about your healthcare. Now, this is an incredibly important point, Lisa. Let me get this point over. Life expectancy in this country is about 82.8 years for women, females, and about 78.8 for males. So I will live, about a little bit less as a man than you as a woman, okay? But importantly, healthy life expectancy has flatlined. So despite all of this input, healthy life expectancy, that's how many years you can expect on average to live in a healthy state, is about 63.2 years for women and about 63.5 years for men, so roughly the same. So when you start to equate that, you start to think, you've got a significant portion of your life on average, where about 19 years for females, 15 to 16 for male, where you'll have chronic disease and be unhealthy. And whatever we're doing so far, has a flat line for decades now. And so that's the measure we should be changing with all of this activity.
I understand what you're saying, but surely if we've got screening for diabetes, screening for cancer, we've got more tests and diagnostics, we can get in early with different drugs, heart disease, we've got statins, we've got all sorts of things that we can give people. And if we get in early with screening, then surely we can pick cases up and improve life expectancy. Are you saying that's not right?
It's not that I'm saying, that's what the data's telling us in terms of health life expectancy. We're going nowhere. What's happening here is, as you medicalize a condition, people think it's okay, I can keep eating the donuts, I can still keep drinking the alcohol, I can still keep putting the weight on, because what's going to happen is the healthcare system out there is going to help me and prevent what happens next. We are facing a sort of doomsday scenario in a couple of areas. One is, as we trend into adult life, obesity is a huge problem. But also what's happening is, in our unhealthy lives, we are accumulating more and more chronic conditions. And we call this multimorbidity. This is people with 2 or more chronic diseases. And by the age of 65, about 50% of people have 2 or more chronic conditions. In the next decade, that is projected to increase to about 2/3, 67% of the population. If you think we can afford that, 67% of people with age 65 or over have 2 or more chronic conditions. There just isn't enough money to pay for that, because what you're saying is it's okay to get diabetes. By the time you're 50, people will be trending into that. They'll be eating more, they'll be overweight. The problem here is, at the moment, is the latest panacea of interventions is it's okay because we've got these weight loss jabs that we're going to roll out. And that will save everybody. So carry on eating as you want. And round the corner.
Why do you not think that's a solution? I know Wes Streeting is wanting to roll them out more widely, and we've got, I think, over 1 million people on them, many privately paying, but they are losing weight.
I think Wes Streeting is almost staking his reputation on these Mounjaro and Ozempic to pull us out of the waters in the NHS. Not only will it let people lose weight, it will change the course of all sorts of diseases. Oh, and by the way, it will get everybody back to work because it's got economic impact. Now, let's be clear. Any weight loss intervention while you're on it works. Slimming World, Weight Watchers, the drugs work. But the problem is about 2 or 3 different things. Number one is they have significant adverse effects. A lot of people can't tolerate it, but also it's got serious effects like pancreatitis. And we're also worried about pancreatic cancer and irreversible blindness. So there are significant issues. The cost of it is exorbitant. So the current strategy is only to give it about 300,000 people. Yet there's about 3.5 million who are actually clinically obese. And actually, if we were to give it to that number of people, it would require about 50% of the drug budget. The cost of it is exorbitant. So what we're seeing, and I'm seeing from my colleagues in general practice, people turning up to GP saying, can I have this on the NHS? And what's happening is they're going, no, you can't. You don't fit the criteria. Currently, you've got to have a BMI of 40 and I think 4 chronic diseases. And they're going, well, you don't meet the criteria. So what they're doing is they're spending their money, and the price of this drug is going up and up because of the demand issues. So about £170 a month to get this drug from the supermarkets, from wherever they can. And what we're saying is this is no fix to the obesity issue. This is a major public health issue that I consider this is malnourishment. The way we consume calories in this modern world is not fit for purpose, and it is detrimental to our health. But the current strategy is, let's sell everybody more food. And once they've ate too much, let's sell them the latest jab that will cure all their ills. That's a vicious cycle for us to be in. We have to have better public health messaging. This is going to take generations to change the course of where we are. Our trajectory in obesity is detrimental to our health, and there are no quick fixes.
We're living in a time of what feels like pretty significant social change, and it makes us question things that we've even taken for granted for decades. And one of those at the moment that people are wondering about is actually money. Is the money in your bank account safe? Should you be investing elsewhere? Are we looking at a potential global crash? What will it mean for your savings? Is there a way that you could be using your money that might be outside of government control even? Well, TallyMoney is potentially one solution. So I'm delighted to say that I'm joined today by the CEO and founder of TallyMoney, Cameron Parry. What is TallyMoney?
Well, at TallyMoney, you basically get gold you can spend. So we give people an individual account in their name, everyday account. They get a sort code, an account number. They use that account just like they would pounds from their bank, but it's milligrams of gold that we brand as Tally.
Okay. Why would you do that, though? What is the benefit to the customer instead of just having a normal pound sterling account?
Gold's performance against the pound is above 11% per annum over the last 25 years on average. But we still need money in our daily lives, and we have savings. We know that it's good common sense and prudent to save up for things, not just living credit. You know, whether it's a holiday or a rainy day, your retirement planning, you need to have money in your life, basically, that you can rely on, that's dependable, that nobody meddles with, that nobody can weaponize against you, which is another element of government control when it's the government currency, which we could talk about another time. And it should be pretty simple and straightforward, and that's what we deliver at Tally. And really, we just want people to feel safe and happy with their money. There was a time when the bigger your bank balance, the more confident you felt. Now it's like, I need to do something with it. I can't leave it there. In Tally, you can.
Okay, brilliant. Cameron Parry from TallyMoney. Thank you so much.
Thank you, Bev.
It's very hard because there's been an epic failure of all public health interventions really to do much. Even the sugar tax did reduce the amount of sugar people consume, but we still had the same amount of people with weight issues. They didn't reduce the weight. You've sort of warned that the NHS has been captured by vested interests, so drug companies, diagnostics and regulators funded by industry. Do you think that's part of the problem, why we're not doing much outside the diagnostics and the drugs? Do you think that's why we haven't really looked and focused hard on how to change people's lifestyles?
So number one is not everything has been a failure, has it? I mean, look, think about smoking. Smoking has a huge impact on your health. Lifelong smokers will live about 10 years less than those people who don't smoke. When the British doctor study was started in the 1950s, about 80% of doctors smoked. Most people thought it was a good thing. However, it seems like as we fix one thing, it's like we replace it with another. And now we've got the issue of vaping and in children vaping and all the harms that potentially come with that. So I think the issue of prevention and public health is you have to keep your finger, if you like, on the button, on the pulse, trying to ensure that we don't introduce too many harms into the environment and into lifestyles for us. And so I personally believe we need to have messaging and start to talk about as a conversation so people understand their own risks. Because ultimately, it's your responsibility. It's not the state's to look after yourself. But what I'm saying is, if we carry on the trajectory, there just isn't going to be enough money to go round to service healthcare. And what's going to happen then is what you're going to see is peeling off of the bits that actually can be privatised, where we can make money, where we can deliver it efficiently. And yeah, you're right. The vested interests across the board are huge here because it is a huge slice of GDP. People want to get in the business of healthcare because you can make lots of money very quickly if you get in the right position, like the weight loss jab people. Now, it's not just healthcare, it's data now. They want access to your data. Maybe we can understand what your healthy lifestyles are like and where we can sell you new products, new tests. We've got off-the-shelf diagnostics now, where you can get your own testing. You've got influencers across the board in social media selling you all sorts of health. And I can tell you, it's very difficult to avoid influencers who are telling you just around the corner, men, we can cure your libido. Here's the latest testosterone. Oh, your hair's falling out. I have a solution for you. They have all sorts of lifestyles, unregulated now, where you as a consumer have to be critical to be able to understand how all of this is being marketed to you. Because healthcare is not just about the NHS. It's all about the well-being, the supplements, all the products you can buy. And there's a huge under the radar where people are receiving funding to promote products right, left and centre.
Yeah. We recently did something on HRT and the number of claims about curing everything from dementia to sort of moods and everything were a huge number online from doctors, and it wasn't supported by the evidence. But can you think of some examples of where we're over using, the use of screening is not worth doing, or the use of certain drugs and medications? It's a one-size-fits-all approach, isn't it, that the NHS can do. Can you kind of just talk about 2 or 3 examples? You've looked at antidepressants, but how we maybe don't need to roll out things to the whole population or to a large amount of the population.
So we need to continually evolve our evidence base around these areas. So, for instance, in breast cancer screening, we have to ask questions. Other countries like Denmark are considering and looking into this and thinking, where's the evidence of benefit to you in breast cancer screening? Importantly, the evidence was derived in populations from the 80s and the 90s, when the treatment was radically different. So the question is, do you put your resources into breast cancer screening, or do you put your resources into effective diagnostics and the new treatments as they emerge? And how you go about
screening, though? I mean, if you're picking up cancers early, surely that's a good thing.
Yeah, no, that's so we run a whole thing called overdiagnosis. Is a detection of a sort of new diagnosis that actually will never cause you any harm. And the problem in cancer is there are these 2 types of cancers. We call them sort of pussycats and tigers. It's a bit of a generalism. But what happens is, and prostate cancer is very much like this, as most men as they get older will get prostate cancer cells, but they will die of something else. Whereas in certain cancers, like in younger people, they tend to be much more aggressive. They're the tigers. Pancreatitis is a bit like that. Lung cancer, by the time you detect it, it's too late. But the important thing is the problem in the outcomes for many cancer studies, it talks about disease progression. It talks about cancer-specific mortality, as opposed to overall mortality is what you're really interested in, and healthy life expectancy. So my position is we need to re-examine in the population now what we call the cost effectiveness of these interventions. because it's not clear to me the evidence from 40, 50 years ago is fit for purpose if you're a 50-year-old woman turning up today with a cancer.
And you're saying
if you've got a lump,
so
the treatment is radically different to when we develop that evidence base. So in a rational approach to healthcare, this is really important. It's the same for cholesterol lowering in primary prevention. I'll give you a very good example. We used to give aspirin to people in primary prevention. Until we discovered it got a better evidence base, we stopped doing it because the risks of a GI gastrointestinal bleed outweighed any benefits in your reduction of risk of cardiovascular events. And that's a classic example where people are now saying, is aspirin assigned to the bin for prevention in heart disease? Because we have learned by developing an evidence base how to go about this differently. So all of the prevention strategies, this is a hard thing. We should be re-looking in the population today and starting to redo the trials independently. Remember, many of these trials were done by industry, and in doing so, we will save money. And when we ensure there's a difference, we should optimize how we deliver those interventions to make sure they're available to everybody today.
So you're saying that with all our cancer screening, or a lot of our cancer screening, we need to relook at the evidence for that because it may be doing people more harm than good, and it may be wasteful.
Yeah, definitely. There are ways it can be harmful, whether it's a false positive diagnosis or particularly receiving an intervention. Now, there are areas where the evidence is better in terms of its quality and what it delivers. So in terms of colorectal cancer screening, the evidence for fecal occult blood is good, if you like, and high quality and makes a difference. The problem is the way it's being delivered, it's not optimized, and actually a high proportion of the population are not taking up the screening intervention. And so what you do is you say, where there's evidence we make a difference, how do we ensure the population receives those benefits? Now, what happens is you see this across the board. You mentioned vaccines. What happens is, as soon as you mention the word vaccine, this is a very difficult area to go into, because you'll get labeled as anti-vax. The debate is so ridiculous at the moment, it is not helping us as a population. Anybody who comes out and says you're anti-vaccine, if they do it after this, is basically saying, I want to shut down the debate. I'm not interested in discussing it, despite the fact they don't do like I and Tom Jefferson at Trust the Evidence, spend hours and hours, literally all of our week sometimes, looking at the evidence. And in doing so, try to understand the effectiveness, the quality of the evidence and the effectiveness. Now, what's happening right now is the population are telling you they've got a problem. Those in government think it's misinformation, but they're going, it's a failure of the evidence base.
Which vaccines, can we look at some of the vaccines? We've got people being offered influenza vaccines right now. We have a lot of controversy around the COVID vaccines that were given to children and people who, I believe your work has shown it wasn't tested on. So let's step into those. So should we be taking the flu vaccine now if we're over 65 and healthy?
Well,
or is it?
I love the first thing you say, the flu. Because soon as you say the flu to me,
illness, yes,
you give rise to the 200 potential pathogens that we know about that could cause you an influenza-like illness. I think that's what now, that's the first thing is to think, is when you go and get unwell, as we trend into winter, everybody will, there'll be children getting unwell now because they've gone back to primary school. Can guarantee it. That about a third of all infections are caused by rhinovirus, which gives rise to the common cold, but actually still in care homes can be deadly. It is a pathogen that can kill people and young children.
And there's no vaccine for that, is there?
No, there's no vaccine for that. So, and there's many, I could talk you, metapneumovirus, parainfluenza, adenovirus. I could keep going the list.
And no
but there's this
for those.
Yeah. So when you say flu, what we're really doing is talking about influenza. Now, influenza can cause you from a mild illness to a severe illness and complications like bacterial pneumonia. It can kill young children and elderly like all of the other acute respiratory infections can do. But importantly is to understand the effect of an influenza vaccine. Now, I ask anybody who's about to label somebody as anti-vaccine, that the number one question is to ask, can you quantify the benefits and harms for me? of the vaccine. Now, when you do that in the randomized control trials, which is Tom Jefferson is my colleague, is the author of the Cochrane Review. There's 52 trials.
It's a gold standard review.
Yeah.
So they looked at all the evidence that was out there,
Yeah.
the good evidence that was out there, yeah.
Yeah, hasn't cherry-picked evidence, has got together all the 52 trials in 80,000 adults. The first thing is to say, in the control group, is in a year in those trials, about 2.3% of people got an influenza infection. So it's not a lot. So you can expect.
So that's the people who didn't have the vaccine.
Yeah.
Yeah. Okay.
Yeah. Now, if you had the vaccine, you can reduce that to about 0.9%. So the absolute difference is about 1.4%. in a year. So relatively, it looks great. What you'll see relatively is, it's a 60-70% reduction. But actually, the absolute...
a lot over a population, no?
Yeah, it could be. It means for about every 71 people you vaccinate, you prevent one infection. Okay? Now, you've got some harms and adverse effects, but that includes local site reactions, but like all vaccines can have some complications. I'll come to the COVID ones because it's better understood. Problem in the influenza is we're not clear because much of the evidence didn't report that. And particularly in children, we're still asking for that data 20 years on.
Really?
Still not been reported. But you could say that's the size of the effect. Now, the important thing is, depending on your risk and your values, this is what's happening in America, is they're going, instead of telling you must do this, we're actually now informing. So you make a decision based on your preferences and values, what benefits you want. And as you get older, your risk and complications will go up. Therefore, you may consider, as I get older, anything that reduces my risk is a good idea, a good notion. But importantly, it's the ability to quantify those benefits so you can make a decision.
Yeah.
This is the most important aspect about evidence-based medicine that we are discussing. You, as a patient, involve your values and preferences. If you decide to take the treatment, that should be okay. If you don't decide to take the treatment, that should still be okay. And if we want to get you to do that, we should improve the size of the effect or the quality of the evidence. That is how you inform a population. Now, when we come to COVID vaccines, the Pfizer one, the Comirnaty one, what has happened here is in America is they've just had their recent ACIP committee, and they are radically changing their view based on the evidence. They reformed their committee for people who are conflict-free. So number one is they've said we can't have people who are being funded by pharma or have got intellectual property or making money out of these drugs.
What's it like here? We've got the medicine...
Well, we've still got people who are conflicted in all sorts of ways because we say, well, you need an expert.
So our drugs are approved by... We have NICE with the National...
So, no, our drugs are approved by the MHRA. That's a regulatory process, which pretty much follows... Is the MHRA? Well, 80% of their funding comes from industry. I mean...
Drug companies.
Yeah. So the people who pay them, they pay you to approve your drug. Is that a conflict?
Is it necessarily a problem? They would just say... Well,
yeah, it's a huge problem.
They would just say, we're experts, where else are we going to get them?
So the problem is in making decisions. Think of it like a jury. If you said, well, what we need is today we're taking this company to court, and you go, well, the jury's got to be made up of people who are from the company to make the decision, you suddenly understand. So I'm a GP. I should be able to understand the benefits and harms. I don't need to make a decision. I don't need to be an expert based on how it works at the cellular level. I need to be an expert in saying what are the benefits and harms and the quality of the evidence. And actually, that's how you should. So that's how you separate out the people involved in developing the drug from those in deciding whether we use it. That's a simple solution immediately. So MHRA approve it. Then we've got people like the JVCI who then sit on committees.
Council on Vaccination and Immunization.
Yeah. And I think, the other thing in America, transparency. All of their committee meetings are online, live video linked. So you will have seen, if you've been on Twitter over the last couple of days, excerpts can appear where somebody says, oh, X said this, Y said that. It can be fact checked. The reason they do that in America is because they understand the decisions that people make will have a huge impact on the share price. So if tomorrow we approve a new vaccine, suddenly the share price, and if they don't do that, they'll get insider trading and all sorts of problems. Ours is completely secret. So we could make that much more transparent, have it live videoed, declare all the conflicts of interest, tell us who the experts are talking to this. That would make a huge difference. Simple fixes won't cost us any more money, but we can view what the decisions are. But with the vaccine of Comirnaty is a 10-year, the COVID vaccine.
Yeah. Mm-hmm.
Yeah, the problem has been a 10-year process has been shoehorned into months. And it's been a failure of the evidence base. I'm not sure we'll ever find out what
So
the
do you
truth
think it's caused loads of heart problems in people? Do you think it's caused heart problems in particularly children? Do you think it's caused turbo cancers? There's lots of
So I think there are some
things out there.
So, there's huge amounts of, and so I think there are some things we know because they're in the summary of product characteristics. We know they increase your risk of myocarditis,
Which is heart.
heart problems, inflammation.
Deadly, yeah.
Yeah, could be, but that's in the product characteristics. Things like
That's
Bell's
in the
palsy.
leaflet, the patient leaflet, yeah.
Yeah, increased risk of Bell's palsy, a neurological condition. We know that no what's called pharmacokinetic studies were done in animals for cancer, which should have normally been done. What regulatory, they all were bypassed.
Really?
We know that at the regulatory stage, there are some new products being used in the vaccines that are novel, and we haven't studied them in depth. We know there are observational studies emerging on both sides. Some say they've saved millions, and other people are saying it's increased your risk of cancer. I think with our current processes and the current approach to evidence, I'm not sure we'll ever find out much more, to be honest. But the way these have been approved is concerning at best. And you could argue in the first few weeks of a pandemic, okay, we may tolerate this because there's huge risk, but actually down the line is we need to really question the whole approval process because it's got holes in it that actually are too big.
And the risks were skewed for some people.
Well, look, a classic example is the transmission. You know, you had people like Fauci saying this is a dead end for the virus. You had people saying, you know, the reason you're taking this is to protect grandma. And yet, when you go into the original study reports and you go to Pfizer themselves says, well, we didn't even study transmission. So nobody could ever talk about it. And I don't know how they got to, but it's in the rush and the frenzy. People got to say all sorts of things that were not true. Now, what happens is...
Why did that happen? Why did that happen and how?
I think because people wanted it to work, but also, you know, the marketing, the competing interests, the too much healthcare. The solution is round the corner, we deliver this and that will solve all of our problems. Everybody was desperate for a solution. And you can see that. But we can't afford to carry on like this. And people are right to question. What you do is you get extremism on both sides now. And the answer is not to censor people or shut them down. I think this is crucial because what's happening here, the debate is polarized because it's a complete failure of how we approved and regulated these drugs and the evidence that was done at the time. Things like pregnant women, you know, the trial that was supposed to be done never got published until years after.
Vaccines, yeah.
And it was failed in its recruitment and its strategy. So we just simply cannot
We never really tested them in pregnant women.
Yeah, that's correct. And we failed in our approach to patient safety. Now, we need a better quality of debate here. We need to get rid of you're anti, you're pro, and this is that. We have to understand the companies are there to maximize the shareholders' profits. And sometimes that matches with our outcome healthcare and sometimes it doesn't.
Do you think healthcare to become an industry in itself? So the profit is stronger than the drive to improve health?
I went to a talk once, which was an American came to the talk, and it was an American talking about how you can make more profits in healthcare. And the talk was something like this, was that in America, 20% of the GDP is in healthcare. And his next line was, the good news is there's still 80% to go after. And that's what we're trying to do. And in doing so, you see it now, Trump And America want us to increase the price of our medicines, want us to pay more. But we're like, hold on a minute, they don't deliver any benefits, more benefits, but you want us to pay more money. And in doing so, you can think it's not just healthcare, it's all the supplements and all the bits around their well-being, that it's a huge portion of the GDP. And I do think we have a huge problem in that I used to think, I've said this, Lucy, I used to think what we would do is we will produce an educated population, a healthy population, and they'd go into the world and they'd create growth. But actually, the current strategy is to get people, I don't think, educated and make sure they're sort of influenced by all sorts of people so they have no idea what's going on, what the truth is, make them unhealthy, and then we'll sell them loads of products. And in doing so, that's how we create growth.
But you can't imagine there's someone doing that. There's not a person somewhere or a group of people doing that. It must be just happy coincidences.
No, I don't think it is. I mean, look, the Tony Blair Institute has put out a report just this week or last week, which said, you know, the answer is more weight loss jabs, and that will transform the economy. That's what they're saying, is if we roll this out, spend tens of billions, somehow the economic benefits will be huge for this country. So they are promoting it. If they don't understand this, they are promoting a message which says it's okay to be on welfare because the future is about us selling you products that will make you healthy. And so basically, sit on your couch.
Won't gain from that. I mean, I'm sure they don't have a vested interest.
Well, they all have vested interests where they're being funded by right, left and centre people to do these reports. But look, if you think what we're going to do is sit on our couch, just eat more, not move, get Amazon to deliver us everything right, left and centre, and then we'll deliver diabetes, drugs and X through your doorstep, and that's our future, then I don't see how we can afford that in any sense whatsoever.
So you would say that instead of spending money on these drugs and the diagnostics, which you think may not be doing as much good as we think, that we could purpose that money and put it into what ambulance handover, improve A&E care, improve cancer care, sort of the front line. Is that what you were saying?
Well, I can tell. Yeah. So look, you look and say, where's the high quality evidence we can make a difference to your healthcare? Most of that is when you have a diagnosis, not when you don't in prevention, because all the prevention is about messaging about us taking responsibility, doing the simple things really well. Now, in doing so, you're right to point out, for instance, a good example will be ambulance care, the golden hour. There's good high-quality evidence that if somebody's having a cardiac arrest, if you get to them efficiently, you can save lives. And every minute counts. So, for instance, you know, in them football matches where the footballers have been saved is because they've got somebody who's an expert on hand who knows how to do defibrillation, is there in a minute. By the time you get to 10 minutes, the outcome is past. It's too late. So level 1 ambulances should get there in 10 minutes. Level 2 should be about 18 minutes. But we can't meet, our average is far exceeding that. And the problem is, come to winter, I'm going to make a prediction. I don't make many predictions. Is there's going to be another winter crisis. Well, because at some point, these ARIs will come. They'll come in a concertina effect where it gets a bit cold and we're all inside huddled together, and RSV, influenza, and all of them will hit us. And the problem is we have a system that is more the same as it has been 40, 50 years ago. Inflexible, inability to understand supply and demand, and flex the system in a way so that if you go to the shops at Christmas, there'll be a few more people working there, stocking the shelves because they know you're going to buy more product. You're going to buy more carrots and sprouts. But in the NHS, it's like, I'm sorry, you're all going to have to wait at the door for hours on end.
Well, to be fair to the government, they've now said for their winter plan this year, they've got 40 emergency care centres. They're going to reduce ambulance handover delays to 45 minutes. I've just been looking this up. They've also said that they would reduce ambulance waits for category 2 cases, sepsis, heart attack, strokes, from 35 to 30 minutes. So they are working on it, and they've had some dummy runs, haven't they, in July, looking at robust winter procedures. Do you not think they are trying?
So I'm on my 17th health secretary now, and there'll be an 18th sometime soon, because these people revolve in and revolve out at that pace. I mean, the longest one actually was Jeremy Hunt. I have to say, I do think, although whatever you think politic-wise, because he was around for a bit, I think he started to understand it a little bit. But we have these plans and promises. I mean, the coffee plan was there that said we're going to solve all these issues, and it emerged again, because it's more about the marketing of what we do politically now than trying to understand how do we fix this and how do we go about ensuring, particularly, there are more people at the front end in the front office and less people in the back office. Now, I can not just talk to you about the evidence, I can talk to you my experience, because I work in a GP in urgent care in a visiting role, and I can tell you it has got worse. Now, when I entered the NHS, I think we were just spending under 40 billion in 97 when the Blair government came in, and they promised to keep that spending the same for 3 years. So it was just under 40 by 2000. Now we go back 25 years on, we're spending 200 billion, and all I've seen it get worse. Now, there were huge problems about that.
Of an ageing population.
So, yeah, you've got this problem of an ageing population. You've got more comorbidity than ever, and we're doing more than ever. The amount of testing we do is out of control in primary care. It is increased 500% in that time.
And you're saying that from the evidence base, we don't know that these tests are actually saving lives or saving more expensive treatments down the line. You're not convinced of that?
Well, look, can you give me a metric? Can anybody send us a metric and say, here's where we're doing better? Because, as I've said, the waiting lists have gone out of control now. I mean, the 7 million people on the waiting list. I mean, it used to be the number that were on it was about 2 million. Now it's out of control. 7 million. All the measures, like operational measures like cancer care waits, are a disaster. We're about to publish a piece on, I read a piece the other day about a young child called Penny Stevens, who basically was a disaster as far as I'm concerned. A 3-year-old who basically went to A&E, was there, supposed to be triaged. It was in 2013. It was busy because of the scare about scarlet fever, remember that? And in doing so, what happened is she waited. She got seen triaged, right? And then I'm calling this a never event, because what happened then is they said, we'll review you in 2 hours. Yeah. And in doing so, what happened is after 2 hours, the mum never got seen. She never got seen. And she said it was like a third world country in A&E. And therefore decided to leave because nobody had triaged her. Despite this child having all sorts of red flags like a rash. She then went home and deteriorated. She obviously had secondary bacterial complications, probably at the time she was in A&E, and then got sepsis. The ambulance took 4 hours to arrive. 4 is out. And I don't see anybody in Parliament, anybody in politics talking about this, thinking about it. This is a huge issue. This is a disgrace. This is a never event that should never happen in our system. Now, this should be a new way of thinking, a wake-up call to go, we cannot have a system where a 3-year-old child cannot be seen by somebody with experience and expertise and triaged appropriately and seen and sorted, because we're talking about 60 to 70 years of life lost because we didn't act appropriately. And I see that as a somber message to us, and a sobering message that means we should go, this is not fit for purpose. And if anybody tells me there's going to be more AI and data, more genomics, more precision medicine, please don't bother, because you need to do the basics really well.
Yeah.
And the simple things in healthcare are, honestly, if you get in front of me, I've been doing the job for 25 years, I'm pretty experienced at what I do. and know how to, sometimes I need to talk to another clinician. I don't need AI and data. I need to talk it through and say, I'm worried about this patient. Where's the consultant? I can get them into hospital now. That's old school medicine.
AI can really help. People are singing the praises, saying that we're going to do AI with 111. People can put their symptoms into a system and they can be triaged that way. Is that, why do you not think that will?
Because we've had attempts to get prediction models for 40, 50 years in healthcare. We've had computer user regression modeling to do that. And AI will do what anybody can do. It will tell you it's helpful when you're really well, and it will be helpful when you're really sick. But actually, there's a huge bit in the middle, which is indeterminate, where it's complex and messy. And what we're interested in is not just your diagnosis. It's not the diagnosis of acute respiratory infection that let Penny down. It was the prognosis. This is the one child today out of 100 who is seriously unwell that I have to do something different and safety net and make sure I treat appropriately, give them antibiotics, give them fluids, do the right things really quickly. The diagnosis is secondary to the complications you're about to face in many situations. That's why people have to train for 10 years in healthcare. To be a pediatric consultant in a busy ED, you're talking 5 years of medical school, and at least 5 years of postgraduate training to be able to recognize the unwell, serious child it's like a needle in a haystack.
What do you do differently that AI can't do?
Well, I'd appropriately, I get the AI to tell me there isn't enough people at the front line and there's too many people in the back office, as I've said. And the AI would say, yeah. Actually, when 100 people turn up, how do you expect to manage them if you've only got 5 people on the front line on a Saturday evening?
Ask, could a computer have given a prognosis and understood the complications with a messy, so they don't ask the right questions? Is that the point?
It's just they can't do the moment-to-moment changes. Look, there's been promises. It's not like diagnostic computer decision tools and all that. AI is just, look, we understand it is just a fancy way of doing something called traditional regression models. Where AI is good is, if I want to go online and use AI to help me understand what is a heart attack, what is cholesterol lowering, just like Google, it's quite useful. But if I want it to help me make decisions, it isn't going to do that, apart from a few where we've got very well derived and validated clinical decision rules. Yeah. And so if you want to know, have you broken your ankle, there's a very good decision rule that can say, for instance, if you can't weight bear and you've got bony tenderness, you've got a high chance of having a fracture. Yeah. But if you can weight bear and no bony tenderness, less than 5% chance of a fracture. Understood. So there are a couple of areas, but the AI is not going to help beyond the bit in the middle where you go, I'm not quite sure. I need a clinician to assess me. Yeah. So look, it is, AI has built on big data, has built on precision medicine. We've had genomics where we're going to apparently screen all newborns with genetics. Yes. And in doing so, that's going to be the answer. Look, the answer is going to be to focus on where we make a difference, and it's high value care, and make sure we do that really well. So I think we've probably reached the end, sadly, of this podcast. But if you were health secretary just for a day or for a week or for a few months, what are the first things you would just scrap and the first things you would fund? Look, I think the first thing is I'd send all of my department on a bit of evidence-based training for a week. And then they come out of that week thinking radically different about healthcare and what they're going to do next. I get rid of the sort of show and tell of the Darcy reports and all the spangled, the banners, and there's a dog, you see, even the dog's had enough. And then I'd focus down on high quality care, where do we make a difference, and stop doing all those things that don't offer value and put them into research to address the uncertainties. Yeah. So, Professor Carl Heneghan, thank you so much for joining us. This is GB News Originals. Please don't forget to like and subscribe below and download the GB News app, available now in the App Store. Thank you, Carl, so much. It was really good. You're welcome. Thank you.
GB News isn't just a channel, it's a family.
And now you can be a part of it. Join our membership for exclusive content and to be part of the conversation.
We're building something different together.
So join us today.
Because your voice deserves to be heard. Become a GB News member today.
Visit gbnews.com/support or scan the QR code on screen now. Thank you.